Welcome to the Deep Dive. We're the show that takes complex information, dense data, and really breaks it down into clear, practical insights for you. Today, we are diving deep into pharmacokinetics. That's how medicines actually move through your body, how they interact with it. And look, this isn't just some academic exercise. This knowledge is absolutely fundamental if you want to truly grasp safe and effective drug therapy. It's about mastering drug disposition like the elite professionals do. Our journey today uses some foundational pharmacokinetic data. It's drawn from a pretty comprehensive appendix, the kind clinicians rely on. We're aiming to demystify all the scientific data, pull out the practical stuff, maybe even some surprising insights that are just essential for making good decisions about medications.
Exactly. And our mission really for you is to systematically unpack these core characteristics, the things about drug disposition that, really drive how dosage regimens are designed. We're not talking about just memorizing facts here. The goal is to connect these scientific principles to their actual real-world impact, especially for individual patients, because everyone's different. So by the end of this deep dive, you'll gain some, I think, really crucial insights into how this knowledge gets applied day-to-day in clinical settings. It's not just about optimizing therapy, but maybe even more importantly, about minimizing those adverse outcomes, ensuring real patient safety. It's about bringing precision to a field that sometimes feels like it relies a bit too much on averages. Okay, so let's map out this journey a drug takes. It all starts with pharmacokinetics, or PK, as it's often called. Basically, PK is the study of what your body does to a drug. Simple as that, right? But it covers a lot. Everything from how it's absorbed, gets into your system in the first place.
Right. The how it distributes itself around your tissues and organs. Then there's metabolism, how your body breaks it down using its chemical machinery. And finally, excretion, how it actually leaves your system.
That's the classic ADME framework. Absorption, distribution, metabolism, excretion.
Exactly, ADME. And understanding these four stages is just the absolute bedrock for using drugs effectively and safely. I mean, without a solid grip on ADME, are we really practicing medicine or just making educated guesses?
That's a really good way to frame it, and it highlights why the source material we're using today is so valuable. It's this meticulously compiled appendix that focuses mainly on small molecule drugs, typical pills and injections most people encounter in clinical practice, delivered either parenterally, like an IV drip, or non-parenterally, like taking a tablet. But to really get the most out of it, it's just as important to know what isn't in there and, why it was left out.
Okay, so what kind of things are excluded?
Well, for instance, a lot of topical drugs, things like eye drops, certain skin creams, they're generally left out because their effect is meant to be local, right where you apply them. They aren't really designed to get absorbed significantly into your bloodstream. So their systemic journey, that whole ADME process through the body, isn't the critical factor for understanding how they work overall.
Makes sense. What else?
Another, maybe more complex, exclusion involves most of those recombinant therapeutic proteins. Think the big biological molecules, like many modern antibody therapies. Except for a few exceptions, like interferons, these are usually not included. And the reason's interesting. Their clinical effectiveness often doesn't directly correlate with how much drug is floating around in your blood.
Huh. How does that work?
They function very differently from small molecules. These large proteins, they have this incredibly specific high affinity for particular targets in your tissues or on your cells. So their exact concentration in the blood isn't necessarily the main driver of their effect. It's more about getting to that specific target and binding really tightly. Think about infliximab, for example, used in autoimmune diseases. It's given at fixed doses, often weeks apart, allowing it to be almost completely cleared from the blood between doses. Its effectiveness isn't about maintaining a steady level everywhere, but about hitting that specific target site effectively.
Okay, so it's a different mechanism altogether.
Right. And similarly, some cytotoxic anti-cancer drugs might be excluded if their effectiveness isn't, reversibly linked to the drug concentration. For these, the mechanism might involve hitting a certain threshold or causing irreversible damage to cancer cells. So again, maintaining a specific circulating level isn't the key therapeutic goal in the same way. And then, of course, there are just practical space limitations. No single appendix can include every single drug out there. The authors had to be selective.
It definitely sounds like they curated this data for maximum clinical relevance, focusing on what practitioners really need to know. So, given the thousands of drugs, how did they pick which small molecules made the cut?
They used some very specific criteria to make sure they included the most, impactful and representative drugs. First, they looked at prevalence of use. They consulted lists like the top 200 selling drugs back in 2020. That ensures they covered the medications you're most likely to encounter.
Okay, so common stuff first.
Right. But second, they also considered the uniqueness of the drug's mechanism of action. So even if a drug wasn't a top seller, it might get included if it worked in a really distinct way, or offered a unique therapeutic advantage, or maybe had a better side effect profile than other options. This gives you a broader understanding of PK principles across different types of drugs, different classes.
That's smart, covers the bases.
Exactly. And finally, they kept it current. They looked at all the new FDA drug approvals between 2016 and 2020. So the list reflects recent developments too. This kind of selective yet comprehensive approach means we're dealing with a really relevant and actionable set of data.
Okay, so we have this carefully chosen data designed to help clinicians. But like you said earlier, just having the numbers isn't enough. You need to understand concepts like clearance, how to interpret these average values. It's about context, right?
Absolutely. And, when you start digging into pharmacokinetic parameters, one of the first things you bump into is variability. Lots of it. It would be fantastic, clinically speaking, if there was just one single, universally agreed upon value for every parameter for every drug. But the reality is much messier. Estimates in the literature can vary, sometimes quite widely. There just isn't always complete consensus.
So how did the authors of this appendix handle that variability?
That required them to use significant scientific judgment. They had to carefully select a single set of values for each parameter. And importantly, they also had to characterize its variability within a relevant population. Most often, you'll see the data presented as a mean value, plus or minus one standard deviation. That gives you a feel for the typical spread around the average. Sometimes, though, you might see a mean alongside a range the lowest and highest values reported in studies. Or, if the data isn't normally distributed, they might use a geometric mean with a 95% confidence interval, or a coefficient of variation, which can sometimes represent skewed data better. If there were several similar studies, they might present a range of the mean values found across those studies. And yeah, occasionally, for some drugs, there might only be a single mean value available from the literature, which, well, tells us less about how much it might vary.
And you mentioned the population.
Yes, and this is absolutely critical to keep in mind. Unless it's specifically noted otherwise, usually with footnotes, this data is typically derived from healthy adults.
Right. That seems like a huge caveat.
It is, because drug disposition can change dramatically in patients with underlying conditions or in different age groups or other demographic factors. For clarity, and also to save space, studies that showed no significant change due to a disease state or only clinically insignificant changes were generally left out of the footnotes. So if you don't see a disease state explicitly mentioned as affecting a parameter, it usually means either no significant change was found or maybe the relevant information just wasn't available. This careful selection process, it really maximizes the data's usefulness for clinicians, helping them make informed decisions for diverse patients. And just to add, when you have something like a prodrug, which gets converted to an active molecule like valganciclovir becoming ganciclovir, the data will often be presented under the active form, ganciclovir in this case, but both might be mentioned to give the full picture. Same idea for active metabolites or stereoisomers, the focus is on clinical utility.
That point about healthy adults is so important. It really drives home that these average values are just a starting point, aren't they?
Exactly. A baseline, but rarely the whole story for a specific patient.
Okay, so with that crucial context set, let's dive into these 8 essential pharmacokinetic parameters. These are the real core components. If you master these, you're well on your way to that professional understanding of drug disposition we talked about. We'll define each one, talk about what influences it, and really explore its clinical significance for you, pulling examples from the data. First up, bioavailability, specifically oral bioavailability. What is this exactly, and why is it so fundamental when we think about drug dosing?
Oral bioavailability, often denoted as F, is a really critical measure. It represents the fraction or percentage of a drug dose taken by mouth that actually reaches your systemic circulation, your bloodstream, in its unchanged active form. You can think of it as the effective dose that actually gets into your system to do its job.
Okay, so it's how much actually gets in.
Precisely. And it's fundamental because it directly impacts the dose you need to give orally to achieve the desired effect. If a drug has low bioavailability, say 10%, you'll need a much higher oral dose compared to maybe an IV dose to get the same amount of active drug circulating.
How do they measure it?
Typically, it's measured by comparing the total drug exposure after you take it orally versus after it's given intravenously. We often measure exposure using the AUC, the area under the plasma concentration time curve. Sometimes you can also estimate it from the amount of unchanged drug recovered in the urine.
So what kinds of things affect how much gets in? What influences bioavailability?
Oh, it's a whole host of factors, really. A complex interplay. One common issue can be the dosage form itself. If it's poorly formulated, the pill or capsule might not disintegrate or dissolve properly in the GI fluids. The drug never gets released.
Right, like a faulty delivery package.
Kind of. Then there's degradative loss. The drug might actually get chemically broken down in the harsh environment of the stomach or intestines before it even has a chance to be absorbed. Poor mucosal permeability is another barrier. The drug just can't easily pass through the lining of the gut. This can even include active efflux transporters, proteins in your gut wall, that literally pump the drug back out into the gut lumen after it's been absorbed.
Wow, the body fighting back in a way.
In a sense, yes. But one of the biggest players is what we call first-pass metabolism.
Ah, yes, you mentioned that briefly before.
Right. This happens when the drug gets metabolized, either as it passes through the intestinal wall or, more significantly, when it goes through the liver via the portal vein before it reaches the general circulation. The liver acts like a big initial filter. Biliary excretion can also play a role where the drug is eliminated in bile, which then goes back into the intestines, reducing the net amount absorbed systemically.
Okay, so the liver is a major checkpoint.
Definitely. And what's really interesting, maybe even counterintuitive, is how hepatic disease, liver impairment, can affect this. For drugs that normally undergo a lot of first-pass metabolism, liver disease can actually increase their oral bioavailability.
How so?
Well, if the liver's metabolic capacity is reduced, less drug gets broken down on that first pass. Or sometimes in liver disease, vascular shunts can form, allowing blood to bypass the liver filtering process altogether. Either way, more of the unchanged drug gets into the systemic circulation. We see this potentially impacting drugs like, say, atorvastatin, the cholesterol drug, or valsartan for blood pressure. Liver health really matters for these.
That's fascinating. What about just eating? Does food impact bioavailability?
Oh, absolutely. Food intake is a major influencer, and its effects can be quite variable, sometimes surprising. For example, alendronate, that osteoporosis drug, has incredibly low bioavailability to begin with, less than 0.7%. And taking it anywhere near a meal, even an hour before or 2 hours after, reduces it even further. That's why the dosing instructions are so specific.
Yeah, I remember those warnings.
Or take alfuzosin for prostate issues. Its extended release form has about 50% bioavailability with a high-fat meal, but only half that, so maybe 25% if you take it on an empty stomach. Huge difference.
So sometimes food helps, sometimes it hurts.
Exactly. For other drugs, food actually increases bioavailability. Drugs like atazanavir, an HIV med, or rivaroxaban, a blood thinner, or even cannabidiol food helps get more of the drug into the system.
Interesting.
Bioavailability can also be dose-dependent. Sometimes it decreases as the dose goes up. Amoxicillin, the antibiotic, is an example. The absorption process can get saturated at higher doses. And genetic polymorphisms, those variations in our genes for drug metabolizing enzymes, can also play a role. We see this with drugs like atomoxetine for ADHD, where your genetic makeup can influence how much drug actually becomes available.
It really paints a picture of complexity. Can you give a few more specific examples from the data?
Sure. Azathioprine is a really striking one. It's an immunosuppressant. The intact parent drug is basically undetectable after you take it orally because first-pass metabolism is so extensive.
Right.
So its bioavailability is actually determined by measuring its active metabolite, captopurine. You're measuring the downstream effect, essentially.
Wow.
Methylphenidate, the stimulant, exists as two mirror image molecules, and enantiomers. The plus enantiomer has about 22% bioavailability, but the enantiomer only has 5%. Again, that difference is mostly down to extensive first-pass metabolism hitting one form harder than the other. And Rameltian, that sleep-aid bioavailability, is incredibly low, about 1.8%, due to massive first-pass metabolism. Yet taking it with food can significantly boost its peak concentration and overall exposure. That might be good or bad, depending on the patient, right?
Absolutely. These examples really show bioavailability isn't just some simple number, it's dynamic. Okay, so after absorption, some drug might get eliminated unchanged. Our next parameter. Urinary excretion of unchanged drug. What does this percentage tell us?
This one's pretty straightforward conceptually. It's the percentage of the total drug dose administered that gets eliminated from your body via urine without being metabolized or changed. It's a direct measure of how much the kidneys are clearing the original drug molecule itself.
So it tells us about the kidney's role in getting rid of the original drug.
Exactly. And the primary factor influencing this is, unsurprisingly, renal function, kidney health. If kidney function is impaired, you'll almost certainly see a decrease in the amount of unchanged drug excreted in the urine for drugs that rely on this pathway. But there's another factor: drug reabsorption back from the urine into the blood within the kidney tubules. And this reabsorption can be heavily influenced by things like urine pH.
How does pH affect it?
Well, for certain drugs like dextroamphetamine, a stimulant, or methadone, an opioid, their excretion is quite sensitive to urine pH. Generally, acidic urine tends to increase the excretion of basic drugs because it keeps them ionized, making it harder for them to cross back through the kidney membranes into the blood. And the opposite is true for acidic drugs in alkaline urine.
Interesting. Any examples from the data?
Sure. Amoxicillin, that common antibiotic, has a high urinary excretion rate, about 86%. This tells us the kidneys are its main route for eliminating the unchanged drug. So kidney function is paramount for dosing amoxicillin. Valsartan, the blood pressure med, its urinary excretion is somewhere between 29% and 50%. This suggests a more balanced elimination, some renal excretion of unchanged drug, but also significant metabolism or other routes. Varenicline, used for smoking cessation, has a really high urinary excretion, 86.2%. It's mostly cleared by the kidneys with very little metabolism. Again, this makes renal function a critical factor for anyone taking it.
Okay, that makes sense. So the drug gets absorbed, maybe some gets excreted by the kidneys right away. What about the drug circulating in the blood? You mentioned it doesn't just float freely. That brings us to binding to plasma proteins. Why track this percentage?
Right. So plasma protein binding refers to the percentage of the drug in your blood plasma that's reversibly attached or bound to proteins circulating in the plasma. The main binding proteins are albumin and alpha-1 acid glycoprotein. Most of these binding percentages you see listed are determined in vitro in lab tests to characterize how tightly the drug binds under specific conditions.
And what influences how much gets bound?
Several things. One is the drug concentration itself. If the drug concentration gets high enough, it can start to saturate the available binding sites on the plasma proteins. When that happens, the percentage bound can actually decrease. For example, the antibiotic azithromycin binds about 50% at lower clinical concentrations, but only 12% at higher concentrations. Valproic acid, the anticonvulsant, also shows decreased binding as its concentration goes up. So a single percentage might not tell the whole story across the entire dosing range.
Okay, so concentration matters. What else?
Disease states are a big one. Things like liver disease, kidney disease, or even systemic inflammation can change the concentration of those binding proteins, albumin and Ag. If you have less albumin, for instance, drugs that bind to it will have lower overall binding. Also, conditions like uremia, from severe kidney failure, can sometimes change the affinity of albumin for certain drugs, meaning the protein doesn't bind the drug as effectively, even if the protein level itself is normal. A good example is doxycycline, an antibiotic. Its protein binding drops from around 88% in healthy people to about 71% in patients with uremia.
So the disease affects the binding capacity.
Exactly, and the type of drug matters too. Generally, acidic drugs like warfarin, the blood thinner, tend to bind mainly to albumin. Basic lipophilic, fat-loving drugs like propranolol, the beta blocker, often bind more to alpha-1 acid glycoprotein.
Okay, now the big question. Why is this clinically relevant? How does protein binding affect treatment?
This is where it gets really interesting and maybe a bit counterintuitive. Changes in protein binding can definitely affect other pharmacokinetic parameters: the apparent volume of distribution, clearance, half-life. But here's the crucial point. It's almost always the unbound drug concentration, the free drug, the portion not stuck to proteins, that's able to leave the bloodstream, get to the site of action, and actually produce the pharmacological effect.
So it's the free fraction that does the work.
Precisely. So think about this. If a patient's protein binding changes, maybe due to kidney disease, the total drug concentration you measure in their blood might go up or down significantly. But if the unbound concentration stays relatively stable, perhaps because the increased free fraction also leads to faster clearance for certain types of drugs, then you might not actually need to adjust the dose.
Even though the total level changed.
Right, because the pharmacologically active unbound level might be okay. Focusing only on the total concentration can be misleading if you don't consider protein binding changes and their impact on the free fraction. It's a really important nuance.
That is a critical distinction.
And you see nuances even within drugs. Take carvedilol, a beta blocker that's a chiral drug, existing in two mirror image forms. The R plus form binds more tightly to plasma proteins than the S form. This difference in binding can affect their individual kinetics and potentially their contributions to the overall clinical effect. It just highlights how complex this can be.
Definitely a deep topic. Okay, moving on. Parameter number 4, plasma clearance, or CL. This sounds like just getting rid of the drug, but what does it technically represent?
Plasma clearance, CL, represents the systemic clearance of the total drug from plasma or blood. Conceptually, you can think of it as the theoretical volume of plasma or blood that gets completely cleared of the drug per unit of time. It's essentially a measure of the body's overall efficiency in eliminating the drug.
Okay, efficiency of elimination. How is it usually expressed?
Most often, you'll see it in units like milliliters per minute per kilogram of body weight, mmol. Normalizing to body weight is common, though sometimes normalizing to body surface area, BSA, is considered more appropriate. This is often done for infants, where organ development might not track perfectly with weight, or for certain anti-cancer drugs like docetaxel or doxorubicin, where dosing is traditionally based on BSA, maybe reflecting a better correlation with the large systemic exposures needed. If the studies didn't report weight, a standard 70-kilogram BAT or 1.73 millimeter BSA might be assumed. And it's important to remember that variability between individuals in that weight-normalized clearance reflects differences in their intrinsic metabolic or transport processes, not just differences in organ size. Although things like obesity or severe malnourishment can affect organ mass disproportionately to total weight, adding another layer.
So what factors have the biggest impact on clearance?
Oh, huge range of factors. Disease states are definitely major players. Hepatic impairment, liver disease significantly reduces clearance for many drugs metabolized by the liver, common pain relievers, statins, antidepressants, you name it. This usually means the drug hangs around longer, increasing exposure and potential side effects.
Right.
Similarly, renal impairment, kidney disease, drastically cuts clearance for drugs primarily eliminated by the kidneys, many antibiotics, some blood pressure meds, etc. Again, leading to accumulation. Even heart failure can impact clearance, mainly by reducing blood flow to the eliminating organs like the liver and kidneys.
What about age?
Age is critical. The elderly often have reduced clearance for many drugs due to natural declines in organ function and changes in body composition. They might be more sensitive to standard doses. And children and neonates are a whole different ballgame. Their clearance rates can vary wildly depending on their stage of development, as their metabolic enzymes and kidney function mature. Pediatric dosing is incredibly specialized for this reason.
Genetics must play a role too.
Absolutely. Genetic polymorphisms, those variations in genes coding for drug metabolizing enzymes or transporters, can have a massive impact. The classic example is the CYP2D6 enzyme. Some people are genetically poor metabolizers via this enzyme, which dramatically reduces clearance for drugs like the beta blocker metoprolol or the ADHD drug atomoxetine. Others might be ultra-rapid metabolizers. Another example is the NETO2 enzyme, which affects clearance of the TB drug isoniazid. Your genetic acetylation phenotype dictates how quickly you clear it.
So your genes can make you process drugs differently.
Hugely differently. Then, of course, there are drug interactions, which we'll get into more detail on later, but they can significantly inhibit or induce enzymes transporters, altering clearance. Other things, too. Smoking can induce certain enzymes, speeding up clearance for drugs like the antipsychotic clozapine.
Yeah.
Pregnancy alters physiology and often changes clearance for various drugs. And some drugs exhibit saturation kinetics. Their elimination pathways can get overwhelmed at higher doses, like a bottleneck. For these, we talk about Cavam and Vmax Michaelis-Menten kinetics. Acetaminophen above about 2 grams is an example, or methylphenidate at high doses. Their clearance isn't constant anymore. It becomes concentration dependent.
So many variables.
It really is a complex picture. You see it in the examples. Acetaminophen cleared mainly by glucuronidation and sulfation, but with that concentration dependence. Alfentanil, the opioid, cleared by CYP3A. Isoniazid, dependent on NAD2 genetics. Metoprolol, cleared by CYP2D6, highly variable between people. It just underscores why understanding clearance is vital for safe and effective dosing.
Absolutely. It's clear. Clearance is dynamic. Now, parameter 5. Volume of distribution, or V. This sounds like it should be a simple volume, but you said it's more complex. What is it really telling us?
Right. The volume of distribution, V, isn't a real anatomical volume. It's an apparent volume. It's a theoretical concept. Imagine it like this. It's the volume of fluid that would be required to contain the total amount of drug in the body at the same concentration as it is in the plasma.
Okay, so it's theoretical. What does a large or small V mean practically?
Basically, it tells you how extensively the drug moves out of the bloodstream and into other body tissues and fluids like fat, muscle interstitial fluid. A drug that mostly stays within the blood plasma will have a small apparent volume of distribution. A drug that distributes widely into tissues, maybe even accumulates there, will have a large apparent volume of distribution, often many times larger than the actual volume of body water.
So a big V means the drug spreads out a lot.
Exactly. It's not all concentrated in the blood. Like clearance, V is usually normalized to body weight.
Yep.
And while it generally increases with body weight, it's not a perfect correlation. It really depends on where the drug actually distributes. If a drug is highly lipophilic, fat-loving, it might distribute extensively into fat tissue, leading to a very large V, especially in someone who is obese.
What influences this apparent volume?
Many of the same factors we saw with clearance. Body size and weight are obvious ones. Disease states can significantly alter V. Hepatic impairment might affect it due to changes in protein binding or fluid balance. Renal impairment can definitely alter body fluid compartments. Heart failure often leads to increased total body water, which can increase V for water-soluble drugs. And obesity, as I mentioned, can dramatically increase V for fat-soluble drugs.
Age again.
Age is a factor too. In the elderly, V might be increased for fat-soluble drugs because body composition shifts towards a higher percentage of fat. Reduced lean body mass also plays a role. In children and neonates, V can be quite different from adults due to differences in relative body water content, fat content, and protein binding levels, which are still developing.
And protein binding must connect here too.
Yes, absolutely. Plasma protein binding influences the apparent V. If less drug is bound to proteins, higher free fraction, more is available to distribute out into tissues, which can increase the apparent V. But again, remember the key point. The clinical outcome usually depends on the unbound drug concentration at the site of action, not just the total amount or the apparent volume it's distributed into.
Can you give some examples of how V behaves?
Sure. Amphotericin B, the antifungal, is interesting. Its steady-state volume of distribution actually increases as the dose goes up. This suggests that at higher doses, it's pushing further out into the tissues. Colchicine, for gout, shows what we call multi-compartment kinetics. It doesn't just distribute evenly, it moves into different body compartments at different rates. So, talking about a single V might be an oversimplification. Lithium, used for bipolar disorder, has a noticeable distribution phase. It takes time, about 5.6 hours for its distribution half-life, for it to fully distribute. This delay influences the drug concentrations you see, especially in the hours soon after taking a dose. It's not instantaneous. These examples show V is also a dynamic, sometimes complex parameter.
It really is about where the drug goes, not just how much is there. Okay, this leads us to what many people think of as the main pharmacokinetic parameter, maybe the most commonly cited one, half-life, or T12. What is it, and why is it so key for deciding how often we take a medication?
The half-life, T12, is conceptually the simplest. It's the time it takes for the concentration of the drug in the body, usually measured in plasma, to decrease by half. But importantly, it's not an independent parameter. It's a direct consequence of both clearance, Cl, and the volume of distribution V. The formula is roughly T12 or 0.693 Cl.
Ah, so it depends on the other two.
Exactly. Which means all the factors we just discussed that influence Cl and V, disease states, age, genetics, drug interactions, will also directly affect the half-life.
So what's its main clinical use?
Clinically, half-life is absolutely fundamental for determining the appropriate dosing interval. How often do you need to take the drug? The goal is usually to maintain drug levels within a desired therapeutic range, avoiding concentrations that are too low to be effective or too high to be safe. Half-life dictates how quickly the drug level drops, and therefore how often you need to replenish it. A drug with a short half-life needs frequent dosing. One with a long half-life can be dosed less often, maybe once a day or even less. It's also worth noting, for those slow-release formulations we mentioned, the observed half-lives might actually reflect the slow absorption rate from the formulation, rather than the true elimination rate from the body once it's absorbed. It's an apparent half-life in that case.
The examples for half-life must be quite revealing.
Oh, they really are. They show extremes. Take alendronate again for osteoporosis. Its half-life related to release from bone is estimated at around 11.9 years. It gets incorporated into the bone matrix and just stays there, being released incredibly slowly. That explains its very long-term effects and dosing schedule. It highlights extreme tissue sequestration.
Wow.
Amphotericin B, the antifungal when it's put into liposomal formulations, its terminal half-life jumps dramatically, maybe 110 to 173 hours compared to the non-liposomal form. That completely changes it from a daily infusion to something given much less frequently. Azithromycin, the Z-Pak antibiotic, has that long terminal plasma half-life of of about 68 hours, reflecting slow release from tissues where it concentrates. But for dosing calculations, the multiple dosing half-life around 40 hours is often more relevant for predicting steady-state levels.
So there can be different half-lives depending on what you're measuring.
Yes, especially with complex distribution or release patterns. Then you have drugs like the dutasteride for prostate enlargement, with a terminal half-life of 840 hours. That's over a month. Fluoxetine, Prozac, its active metabolite, norfluoxetine, has a half-life of about 6.4 days, extending up to 12 days via liver cirrhosis. That means the active drug effect persists for a very long time after stopping the medication. Hydroxychloroquine, another super long one, 156 hours, that's 44 days. Explains why it takes so long to build up levels and also so long for it to clear. Morphine, its active metabolite, morphine 6-glucuronide, normally has a half-life of about 4 hours. But in kidney failure, it can accumulate, and its half-life can stretch to 50 hours, causing prolonged sedation or respiratory depression. Or paliperidone given as a long-acting injection. It might have an apparent half-life of 25-49 days, but that's mostly reflecting the slow dissolution and release from the injection site, not the body's elimination rate itself.
These examples really hammer home how variable half-life is and how critical it is for dosing frequency and managing accumulation, especially with metabolites or specific formulations. Okay, on to our final pair of parameters, which are closely related and tell us about the peak effect. Time to peak concentration, Tmax, and peak concentration, Cmax. Let's start with Tmax. What does that tell us?
Tmax is pretty straightforward. It's simply the time it takes after administering a drug to reach its maximum concentration in the plasma or blood. It's basically a direct indicator of how fast the drug is absorbed.
So what influences how quickly you reach that peak?
Primarily the drug's formulation. An immediate release tablet will generally have a much shorter Tmax than an extended release or sustained release version of the same drug, which is designed specifically to slow down absorption. Food intake can also significantly affect Tmax. Depending on the drug and the type of food, eating can either delay Tmax, speed it up, or sometimes not affect it much at all.
And clinically, why is knowing the Tmax important?
Well, it's absolutely critical for drugs used in acute situations where you need a rapid onset of effect. Think about taking something for sudden severe pain or a pill to help you fall asleep quickly. You want a short Tmax in those cases.
Yes, you want it to work fast.
Exactly. Conversely, for managing chronic conditions, we often don't want a rapid peak. Using sustained or extended release formulations helps to slow absorption, leading to a longer Tmax. This allows for less frequent dosing, maybe once or twice a day, and importantly, it helps minimize those big swings between the peak, Cmax, and the trough, lowest concentration just before the next dose. Avoiding those big fluctuations can improve tolerability and maintain a more consistent therapeutic effect. This ties directly into Cmax.
Can you give some Tmax examples?
Sure. Alfuzosin, in its 10 mg extended release form, has a Tmax of about 9 hours. That slow absorption allows for once-daily dosing for prostate symptoms. Elostron, for IBS, has a Tmax of just 1 hour for a standard oral dose, reflecting its rapid absorption for relatively quick symptom relief. Dextroamphetamine, something like Adderall XR, the extended release version, has a Tmax around 7 hours, much longer than the immediate release forms, giving that smoother, longer-lasting effect profile. And riluzole for ALS is interesting. A high-fat meal not only decreases its overall clearance, but also increases its Tmax. It takes longer to reach the peak if taken with fatty food, something important for patients to know regarding meal timing.
Okay, so Tmax is about when the peak happens.
That leads perfectly to our final parameter, peak concentration, or Cmax. What's its significance, especially regarding effectiveness versus side effects? Cmax is simply that maximum concentration reached in the plasma or blood after the drug is given. And it's incredibly important because it often directly relates to both the drug's efficacy and its potential for causing side effects or toxicity.
So higher Cmax might mean stronger effect, but also higher risk.
Generally, yes, although the relationship isn't always linear. For many drugs, there's a therapeutic window. You need the concentration to be above a minimum effective level, MEC, but below a minimum toxic level, MEC. Cmax is often the point where you're most likely to exceed that MTC if the dose or absorption rate is too high. Comparing Cmax values between different formulations is really insightful. For the same total daily dose, an immediate release IR product will have a much higher Cmax than an extended release ER product. ER formulations are specifically designed to lower the Cmax and smooth out the concentration profile, minimizing those peak-trough fluctuations. This is key for avoiding side effects associated with high peaks or preventing loss of efficacy if the trough level drops too low between doses. Think of drugs like felidipine for blood pressure or methylphenidate for ADHD. The ER versions offer a more tolerable and consistent effect largely by managing Cmax.
Are there defined Cmax targets or danger zones for drugs?
Sometimes, yes. Where possible, researchers try to define minimum effective concentrations or toxic concentrations. These give clinicians concrete targets. For instance, with acetaminophen overdose, liver toxicity is a major risk if the concentration is above 300 micrograms per milliliter 4 hours after ingestion. That's a critical Cmax-related threshold. Indomethacin, the anti-inflammatory, works best between 0.3 and 3 minim, but levels above 5 g-metal are associated with toxicity. Furosemide, the diuretic, can cause hearing damage, odor toxicity, if concentrations exceed 25 g-mol. For morphine, the minimum concentration generally needed for pain relief, minimum analgesic concentration, is around 15 ng/ml. These numbers help guide dosing and monitoring.
And what about those active metabolites or different enantiomers? Do they factor into Cmax considerations?
Absolutely critical. You have to consider the contribution of active metabolites. Sometimes they are more potent than the parent drug, or they accumulate to higher levels, especially if organ function is impaired. We mentioned atorvastatin's active metabolites contributing to its effect. Irinotecan, the chemo drug, gets converted to SN38, which is way more potent. Its Cmax is highly relevant for toxicity. Morphine's metabolite, M6G, accumulates in kidney failure, and its Cmax drives potential toxicity. Tamoxifen relies on metabolites like indoxafen for much of its anti-estrogen effect. Similarly, for chiral drugs like warfarin or metoprolol, the different enantiomers can have different potencies and different Cmax profiles. You need to understand the kinetics of the active forms.
So it's not just the parent drug's peak.
Definitely not. You need the full picture. It's worth noting, though, that specific effective or toxic concentration ranges aren't always explicitly stated in drug labels. They're often inferred by clinicians based on experience and studies linking concentrations to outcomes. Ideally, we'd have more data on average steady-state concentrations, CSS, but that's often not readily available in standard references.
This breakdown of the 8 parameters is incredibly thorough. It really feels like we've taken apart a precision machine to see how it works, but it also highlights the huge challenge. These are mostly average values from healthy people. How do we actually use this knowledge to tailor treatment for a specific individual patient? This brings us right to the crucial topic: alterations of parameters in the individual patient.
This is exactly where the science of pharmacokinetics meets the art of clinical practice. Because you're right, those table values are averages, often from healthy adults. Real patients deviate, sometimes significantly, and that necessitates careful consideration and often dose adjustments. The primary source for specific numerical dose adjustment recommendations should always be the official FDA-approved product information or robust, peer-reviewed clinical literature. Our discussion here is more about understanding the principles and directions of change.
Does a change in parameters always mean a dose change is needed?
Not necessarily. It depends partly on the drug's therapeutic index. If a drug has a wide margin between its effective dose and its toxic dose, then even significant pharmacokinetic differences might not require a dose adjustment. There's more room for error, so to speak. But for drugs with a narrow therapeutic window, where the effective and toxic doses are close together, even small changes in PK parameters due to individual factors can be critical, and adjustments are often essential.
So what are the main patient-specific factors that drive these alterations?
Well, we've touched on many already, but let's consolidate. Disease states are paramount. Chronic liver disease, LD. This typically decreases the clearance of drugs metabolized by the liver, leading to increased half-life and higher overall exposure. Think about sedatives, statins, some antidepressants. Their effects can be greatly amplified. For some drugs, like allosterone for IBS, the exposure, AUC, can increase 1.6 to even 14-fold in liver impairment. A standard dose could become toxic.
Wow, that's a huge range.
It can be renal impairment, RD, or kidney disease. This is crucial for drugs eliminated by the kidneys. Clearance drops, half-life increases, leading to accumulation of the parent drug or active metabolites. This affects countless drugs, antibiotics like ciprofloxacin or amoxicillin, blood pressure meds like lisinopril, pain meds like gabapentin or morphine metabolites. Dose reduction is often mandatory based on the degree of kidney function loss. Even heart failure can alter PK, impacting both clearance due to reduced blood flow and volume of distribution due to fluid shifts.
Okay, so organ function is key. What about other factors?
Age is a big one. We talked about the elderly often having reduced clearance and potentially altered V, making them more sensitive. Neonates and children have highly variable and evolving PK parameters due to their immature systems, requiring specialized dosing. You can't just scale down an adult dose based on weight. Their pathways might work completely differently. Pregnancy induces significant physiological changes that often increase the clearance of many drugs, potentially requiring dose increases to maintain efficacy for drugs like lamotrigine or certain antibiotics. Smoking can induce metabolic enzymes like CYP1A2, increasing the clearance of drugs like clozapine or olanzapine, meaning smokers might need higher doses than non-smokers. And obesity can alter the volume of distribution, especially for fat-soluble drugs, and sometimes affect clearance, necessitating careful thought about whether to dose based on actual or ideal body weight.
It's a lot to juggle. You also mentioned prodrugs and metabolites again.
Yes, it's crucial to understand the full picture. Is the drug you administer the active form, or is it a prodrug that needs conversion? A classic example is prednisone, inactive, converting to prednisolone, active. They can even interconvert, making it complex. And are there active metabolites? Do they contribute significantly to the effect or potential toxicity? We saw examples like hydrocodone converting to the more potent hydromorphone, irinotecan to the super potent SN38, morphine to M6G, which accumulates in renal failure, spironolactone having multiple active metabolites, etoxafen relying on endoxifen. You have to consider the kinetics of these active forms, not just the parent drug.
And the chiral drugs.
Right, chiral drugs add another layer. Many drugs are mixtures of two enantiomers, mirror images. These enantiomers can have different pharmacological activities and different clearance rates.
Yeah.
Carvedilol, methylphenidate, metoprolol, warfarin, they all have enantiomers with distinct properties. Treating the racemic mixture as a single entity can sometimes mask important differences in the exposure to the more active or more toxic form.
It's incredibly complex.
It is. And again, while we're outlining the principles, specific quantitative dose adjustments must come from authoritative sources like the drug label or specialized literature. These are high-stakes decisions.
Absolutely. This intricate picture of individual variability leads perfectly into our final major topic, the complex web of drug interactions, or DDIs. We know they can affect clearance, but let's really focus on them. These are so critical as seemingly minor combinations can have major clinical consequences. Our source specifically highlights interactions causing at least a 5-fold change in exposure.
Yes, DDIs are a massive area of concern in medicine, especially with patients often taking multiple medications, polypharmacy. We talk about a perpetrator drug causing the interaction and a victim drug whose pharmacokinetics are altered. The magnitude varies hugely, but for this discussion, we're focusing on the really significant ones, what the FDA often terms strong interactions. That threshold is typically defined as causing at least a 5-fold increase in the victim drug's AUC, total exposure, or for inducers, causing at least an 80% decrease in the victim drug's AUC.
Why that specific threshold?
Because interactions of this magnitude almost always have clinical consequences. A 5-fold increase often pushes a drug into toxic territory, while an 80% decrease usually renders it ineffective. These levels often mean co-administration is contraindicated or requires very significant dose adjustment of the victim drug, along with careful monitoring. We quantify this using the AUC ratio, AUCR, the AUC of the victim drug with the perpetrator divided by its AUC without. It gives a clear number representing the potential fold change in exposure, often reflecting the worst-case scenarios seen in studies.
And understanding how they interact is key.
Absolutely. Understanding the mechanism is vital. Is the perpetrator inhibiting or inducing a specific metabolic enzyme, like CYP3A4, CYP2D6, or a transporter, like P-glycoprotein OATP1B, that's responsible for clearing the victim drug? Knowing the pathway helps predict and manage interactions. This information often comes from in vitro lab studies initially. And of course, the dose of the perpetrator matters. A higher dose of an inhibitor generally causes a stronger interaction.
Okay, let's look at some examples. First, the sensitive substrates. These are the victim drugs, the ones whose exposure gets dramatically increased by inhibitors.
Right. These are drugs where adding an inhibitor causes at least that 5-fold jump in their AUC. They are particularly vulnerable. Take elostron, used for IBS. Co-administering it with fluvoxamine, a strong CYP1A2 inhibitor, increases its AUC by 6-fold. That could significantly increase its side effects. Atazanavir, an HIV protease inhibitor, sees its AUC skyrocket nearly 26-fold when given with ritonavir, which strongly inhibits CYP3A. This interaction is actually used intentionally in HIV therapy to boost atazanavir levels, but it shows the potential magnitude. Atorvastatin, the common statin, its AUC increases 5.6-fold with the antifungal atraconazole, a CYP3A inhibitor, and 8.5-fold with rifampin, which inhibits the OATP1B transporter involved in its uptake into the liver. This dramatically increases the risk of statin-related muscle toxicity, myopathy.
That rifampin one is interesting, affecting a transporter, not just metabolism.
It's exactly. Transporters are increasingly recognized as crucial sites for DDIs, Ramelteon, the sleep aid. We mentioned its low bioavailability. But with sulvoxamine, a CYP1A2 inhibitor, its AUC increases by a staggering 190-fold.
190.
Yes, it transforms it. This could lead to profound sedation, respiratory depression. It's an extreme example of how dangerous an unrecognized interaction can be. Sildenafil, Viagra, its AUC increases about 10-fold with ritonavir, a CYP3A inhibitor. That's why much lower doses are used if they must be given together to avoid severe hypotension. Simvastatin, another statin. Its AUC jumps over 16-fold with grapefruit juice. Grapefruit inhibits intestinal CYP3A. It's a classic, common interaction many people aren't aware of. That morning grapefruit could seriously increase your statin risk. Or tacrolimus, an immunosuppressant vital for transplant patients. Its AUC increases 78-fold with telapravir, an older hepatitis C drug that inhibits CYP3A. Managing interactions like this is critical in transplant medicine.
Those numbers are just incredible. 190-fold, 78-fold. It really drives home the potential danger. Okay, now let's flip it. What about the perpetrators? The strong inhibitors and inducers, the drugs that cause these massive changes.
Right. These are the drugs you need to watch out for when prescribing or taking other medications. Let's start with strong inhibitors. These cause at least a 5-fold increase in a victim drug's AUC. Ciprofloxacin, a common fluoroquinolone antibiotic, strongly inhibits CYP1A2. It causes a nearly 10-fold increase in the AUC of tizanidine, a muscle relaxant. Risk of low blood pressure, sedation. Fluconazole, an antifungal, is a strong CYP2C19 inhibitor. It causes a 13.5-fold increase in omeprazole, a proton pump inhibitor, exposure. Itraconazole, another potent antifungal, inhibits both CYP3A and P-glycoprotein. It causes an almost 11-fold increase in midazolam, a sedative, AUC, and a nearly 7-fold increase for dabigatran, an anticoagulant, PGP substrate. Very risky combinations. Ritonavir, as we saw, is a powerhouse CYP3A inhibitor. It causes that 26-fold increase in midazolam AUC. Even newer drugs like ribociclib, a cancer drug, protein kinase inhibitor, can be strong inhibitors. It causes a 5.2-fold increase in midazolam AUC via CYP3A in addition.
So inhibitors boost the victim drug levels, potentially causing toxicity. What about the inducers? They do the opposite, right?
It's exactly. Strong inducers cause at least an 80% decrease in the victim drug's AUC, so the AUCR is 0.2 or less. They essentially accelerate the victim drug's metabolism or transport, often making it ineffective. Carbamazepine, an older anticonvulsant, is a well-known strong inducer. It reduces quetiapine antipsychotic exposure by 87%, AUCR 0.13 via CYP3A induction. It reduces bupropion antidepressant exposure by 90%, AUCR 0.10 via CYP2B6 induction. These victim drugs are likely to fail therapeutically if given with carbamazepine without major dose increases.
So it just wipes them out.
Pretty much. Rifampin, the antibiotic, is perhaps the most potent inducer known across multiple pathways. It reduces omeprazole exposure by 93%, AUCR 0.007 via CYP2C19 induction. It reduces budesonide inhaled steroid exposure by a staggering 99.7%, AUCR 0.003 via CYP3A induction. Budesonide would be completely useless for asthma if taken with rifampin. And ritonavir, interestingly, while a strong inhibitor of CYP3A can actually induce other enzymes like CYP2C19, it causes an 84% decrease in voriconazole antifungal exposure, AUCR 0.16.
So one drug can be both an inhibitor and an inducer for different pathways.
Yes, which adds yet another layer of complexity. The net effect depends on which pathway is dominant for the victim drug. But the big picture here is clear. These strong interactions are not subtle. They fundamentally alter drug exposure, potentially leading to severe toxicity or complete therapeutic failure. Recognizing these perpetrators and victims, understanding the mechanisms, enzyme or transporter, and appreciating the magnitude of change is absolutely paramount for safe and effective medication use, especially in patients taking multiple drugs.
Wow. This deep dive has really peeled back the layers on just how intricate and precise modern pharmacology needs to be. From the subtle ways bioavailability works to the dramatic, sometimes dangerous consequences of drug interactions, it's clear that understanding these pharmacokinetic parameters isn't just academic jargon. It directly impacts patient safety, treatment success, everything. It's truly a testament to the complex, unique relationship between our bodies and the medicines we rely on.
It really is. And that complexity, that individuality, leads us to a final thought for you, our listener, to maybe chew on. Given everything we've discussed, this intricate, highly variable nature of drug disposition in every single person, influenced by our unique genetics, our health status, lifestyle factors like diet or smoking, and that incredibly complex web of potential drug interactions. How can the future of personalized medicine really harness these detailed pharmacokinetic insights? Can we realistically move beyond relying on average patient data and population-based dosing? Can we get to a point where we create truly precision medication regimens, meticulously tailored for each individual based on their specific PK profile, their unique biological blueprint?
That's the ultimate goal, isn't it?
It is. It remains a huge challenge, absolutely. But it's also a tremendous opportunity, isn't it, to potentially revolutionize drug therapy, to move towards a genuine mastery of how we use medicines in every single patient. Something to think about.
The truly fascinating and vital question for the future. Thank you for joining us on this deep dive. We really hope this exploration has sparked your curiosity, deepened your understanding, and maybe even equipped you to approach this information like the elite professionals we talked about. Until next time, keep exploring, keep questioning, stay curious,